Hey, this is Joe Hartman with intraoperative as well as Sentient Medical, and this is the fifth video in the series of this CNIM crash course, and this one will cover ABRs. So let's go ahead and get into it, but first we need to do a little bit of background learning. So this slide has on the lower left here the anatomical areas for hearing. We'll get into that in some greater detail, so I won't go over it just yet. On the lower right side is some of the surgical cases that we typically use ABRs on. The CPA tumors, like acoustic neuroma tumors, those are classic ones where we use auditory evoked potentials. Same thing with microvascular decompression of cranial nerves 5, 7, and 9. That has mostly to do with retraction on the cerebellum in order to get a good enough exposure to do that decompression. There's other cases like skull fractures or fracture of the C1 or 2. Those are a little bit more questionable. The rationale is that the lateral lemniscus, which the auditory pathway goes through, has a different vascular supply than the SSEPs or MEPs, so you can cover a broader area of the spinal cord or lower brainstem in case of some kind of ischemic event. We also use auditory evoked potentials and Chiari malformations. When a surgeon does bony decompression, they'll look over you and says how the BAERs. They're looking to see a reduction in the latency of wave 5 or a reduction in the peak interval of between 1 and 5. If they see that reduction, they believe that bony decompression is sufficient for that patient and they do not need to do the duroplasty, which is a little bit controversial in of itself. I have a post on the blog that goes over my experience with those kind of cases, so make sure to check that out. And other vascular surgeries that deal with the posterior circulation. So brainstem auditory evoked potentials are used to monitor hearing. And that's not completely true. It's more to assess the pathway of hearing. It monitors from the distal nerve through the brainstem to the level of the lower mesencephalon, but not above that. So now we're not talking about hearing, we're talking about ABRs. Hearing goes all the way to the temporal lobe, the Herschel's gyrus. But on ABRs, we only monitor from the distal cochlear nerve all the way to the mesencephalon or the inferior colliculus of the mesencephalon. And we'll get into those anatomical areas and where the generators are. Instead of electric current like we use for SSEPs and MEPs and other modalities, sounds are used to stimulate the auditory pathway. In the operating room, clicks are used to stimulate the cochlear nerve, and that's just because it has a large spectrum of frequency in the click, a long bandpass. In order to fully understand what we are monitoring with BAERs, we need to understand the anatomy and physiology of hearing pathway. So in that lower picture on the left, we have the outside of the ear with the tympanic membrane. When you hear a sound, that kind of vibrates, which sends off these bones to vibrate, which sends off this cascading event of fluid causing hair malformation or just sweeping it to the side. And we'll get into that whole process of how it changes from a mechanical to a sensory neural process. And then in the lower right-hand picture, you can see where cranial nerve 8 is coming into the brainstem. It's that yellow cranial nerve marked there. So the events involved in hearing. The first event is a sound wave arrives at the tympanic membrane, and it causes it to vibrate. The ear converts physical vibration into nerve impulses. It's a biological microphone. It takes this vibratory sound, transduces it into an electrical signal, and shifts it out to be processed. So sound, since we can't see it, is a little bit hard to conceptualize, but if we think about it in a sinusoidal wave, it's a little bit easier. So if we click our tuning fork, we see the arms on it vibrating in and out, and we can assume that this is like a compression and expansion of the air molecules by the tuning fork itself. If we click it a little bit harder, we get a perceived loudness change. So we perceive it as more loud, and that can be thought of as the amplitude becoming greater. If it's a different kind of tuning fork that has a higher pitch or a faster frequency, those two go hand in hand with the frequency or the wavelength of one cycle and the pitch. So the perception of amplitude is loudness. So the larger the amplitude, the louder we perceive it. This is measured in decibels, and the number of decibels equals this mathematical equation, 20 logarithm of pressure over P0. The decibel scale relates to the amplitude of the stimulus to the physiological experience of loudness. So now we have this, on this right side, we have this chart where we're looking at decibels versus the power ratio. And it's from that equation that's up there on the upper left-hand side. And it's easy to see a pattern here. And it's kind of a cheat sheet for when you get asked a question that is asking you to convert decibels to a power ratio or vice versa. So if we look at 10, we see the number 1 in 10, and there's only 1 0 in the power ratio. If we look at a decibel of 40, we see that there's 4 zeros. 60 seems to be the decibel level that they like to give on the CNIM, and there's 6 zeros there. So that is an easy way of knowing which answer to pick for the best without even knowing how to really plug it into the mathematical formula. The decibel, or dB, is the logarithmic unit of sound intensity. The number of decibels divided by 20 is the number of zeros in the ratio to 1. So a decibel of 1/10, a decibel is 1/10 of a bell, or 1 bell is 10 decibels. Then a bell, or 10 decibel, represents the ratio between two power quantities of a 10-to-1 ratio. This picture just gives you an idea about the level of click power that we're using, or loudness that we're using, compared to what we're used to seeing or experiencing out in our world. So if we're at around 100 decibels per sound, or SPL, that's close to that heavy truck, or just less than that jackhammer. So that's pretty loud. This should not be surprising to any of us, but as we age, we have hearing loss, and it happens at faster frequencies. And it's also environmentally driven, so people were left on this island that never left, and they had better hearing than people that were on the island and then left for more than a couple years. So the next areas on our events into hearing is movement of tympanic membrane causes displacement of the auditory ossicles. That's those 3 tiny little bones, the malleus, the incus, and the stapes. And the stupid way I remember this is just somebody whispering in my ear, MIS, spelling out Mississippi, because that's the order that goes in from peripheral to central as MIS, or the malleus, incus, stapes. Movement of the stapes at the oval window establishes pressure waves in the perilymph of the vestibular duct. So the stapes is that little pitchforking looking one. It's connected to the oval window, which is on top. It causes this vibration inside the middle ear, which causes this perilymph to vibrate over the basilar membrane, and then it kind of comes right back down out and has this round window. So the vibration of the footplate of the stape vibrates the perilymph in the bony cochlea. This fluid is essentially incompressible. Therefore, it has to be a counter opening in the labyrinth to allow fluid space to expand when the stape's foot plate moves inward, and in turn to move inwards when the stape foot plate moves outward. This counter opening is provided by the round window membrane, which lies beneath the oval window in the inner wall of the middle ear. So if the oval window is being pushed in, then our round window is being pushed out. It's that counterbalance. The malleus moves due to vibrations of the tympanic membrane. So they might ask which of these bony structures is attached to the malleus, or which one's attached to the oval window, or the stapes is attached to what area, the round window, oval window. You have to know it's the oval window. So just try to get those in place in your mind. The incus transmits vibration to the malleus. The stapes transmits vibration of the incus to the inner ear via the oval window of the cochlea. The stapedius is the smallest skeletal muscle in the human body. So that's whenever it's the smallest or the largest or the first or the last, you should try to memorize what that is, because those are easy and honestly lazy neuroanatomy questions that they could ask. So the stapedius is the smallest. Its purpose is to stabilize the smallest bone in the body, the stapes, to dampen its sound. It is innervated by the nerve to stapedius, a branch of the cranial nerve 7. This is the first branch off the facial nerve after it exits the facial canal. So for me, the easiest way to remember cranial nerve 7 to the stapedius is they both have S's in it. So 7 stapedius. And we'll see another small muscle, the tensor tympani, adjoins part of the great wing of the sphenoid of the handle to the handle of the malleus to dampen sound, namely chewing. It is innervated by the tensor tympani nerve, a branch off of the mandibular division of the trigeminal nerve. So tensor tympani T, trigeminal nerve T, stapedius S, cranial nerve 7 S. That's how I remember it. Both of those muscles are responsible for dampening sound. So if there's a loud siren coming by, those muscles will fire off so you're not subjected to that loud, annoying, possibly damaging sound. Where the tensor tympani muscle is more for this internal noise like chewing or the pulsation of an artery or something like that. And it's called hyperacusis when you lose that ability of those muscles. You're hypersensitive to the sounds around you or inside you. The cochlear nerve is a sensory nerve that transmits acoustic energy or sound impinging on the tympanic membrane or the eardrum. The cochlear nerve arises from within the cochlea and extends to the brainstem, where its fibers make contact with the cochlear nucleus, the next stage of the neural processing in the auditory system. So here we are on the next stage. The pressure waves distort the basilar membrane on their way to the round window in the tympanic membrane. And it's this mechanical distortion that we're going to see causes a depolarization, which leads to an electrical signal. So first, let's differentiate the oval versus the round window. The stapes pushes and pulls the flexible oval window in and out of the vestibular canal at the base of the canal. If sounds are extremely intense, any remaining pressure is transmitted through the helictrum and back to the cochlear base through the tympanic canal, where it is absorbed by another membrane, the round window. Next event is the vibration of the basilar membrane causes vibration of hair cells against the tectoral membrane. The bony cochlea is so called because it is shaped like a snail shell. So here we see it here, this outer bony structure is shaped like a snail shell. It has 2.5 turns and houses the organ known as the membranous labyrinth surrounded by a fluid called perilymph. The cochlea has a volume of about 0.2 milliliters. In this space lies up to 30,000 hair cells, which transduces vibration into nerve impulses and about 19,000 nerve fibers, which transmit that signal to and from the brain. It's easiest to think of the membranous labyrinth by imagining that the cochlea to be straightened out as a bony tube closed at the apex and open at the base with the round and oval windows and a connection to the vestibular labyrinth. So here we see these rings. These are the semicircle canals. That's more of your awareness to your horizon, your vestibular area. Here are the stapes and the other bones, your tympanic membranes out here, your oval windows on top, round window on bottom, vibration of the oval window coming down the basilar membrane. This is the base. This is the apex. This would be in the middle of the snail shell. This is the outer area. And it just causes this mechanical movement of the basilar membrane. If it is a fast frequency, this movement is at the base of the basilar membrane, or this area here. So we see this very fast frequency stops at the base. Slow frequency makes it all the way to the apex, or the very end of it, or the very internal part of that snail shell. I don't know why, but this has been a question that has popped up from what I've heard multiple times on different people's tests. So fast frequency at the base of the cochlea, slow at the apex. The cochlea is shaped like a snail shell and has 3 fluid-filled compartments, the scala, which are separated by cochlear partitions or the basilar membrane, and Reisner's membrane. So here we have the 3 canals here we have Reisner's membrane, and here we have the basilar membrane itself. In hearing, the stereocilia transform the mechanical energy of sound waves into electrical signals for the hair cells, which ultimately leads to the excitation of the auditory nerve. When the stapes causes sound waves in the endolymphatic fluid in the cochlea, the stereocilia are deflected in a shearing motion, which results in the mentioned electrical signal of the hair cells. So here we have an arrival of a pressure wave bending the stereocilia coming this way here. Potassium channels open in response to this bending and causes a depolarization down the cell here. This depolarization causes an inflow of calcium, and this calcium causes synaptic vessels to fuse with plasma membranes. Neurotransmitter is then released and diffuses to the afferent neuron. So here we have this mechanical, here we have this release of potassium causing depolarization, causing neurotransmitter release. Now an electric signal is gone through the nerves. And that brings us to the last event, information about the region, or the base or the apex, and the intensity of the stimulation is relayed to the central nervous system over the cochlear branch of the cranial nerve. So that's how we take a sound or a vibration and turn it into an electrical impulse. Now let's look at that electrical current from the nerve to the brain and how we use that to record potentials. So the first one here is just kind of a gross review of what we just said. Stimulation of the hair cells at the specific location along the basilar membrane activates sensory neurons. So it's gone through that whole process we just talked about. Now these sensory neurons carry sound information in the cochlear branch of the vestibular cochlear nerve to the cochlear nucleus on that side. So this is the distal portion of the nerve coming down to the proximal and synapsing at the cochlear nucleus within that medulla. Information ascends from each cochlear nucleus to the inferior colliculus of the membrane. So we can see an ipsilateral channel coming up to the inferior colliculus. This is the lateral lemniscus. We also see a contralateral, so it is going bilateral. That's how your auditory system is bilateral. Here it crosses over at the trapezoid body and comes up to the contralateral inferior colliculus. The inferior colliculus directs a variety of unconscious motor responses to sound. I don't know if you're familiar with the lizard brain or the old archaic brain. It's more fight or flight. So if you hear like a twig snapping over on your left, you'll have that reaction to look to your left. It's a survival mechanism. It's your reflex, lower brain reflexogenic activity, and that's what the mesencephalon is, one of the areas that drives that. If we look at the superior colliculus, that's more for light. Inferior colliculus is the sound. Once it synapses at the inferior colliculus, it continues up into the thalamus and to the medial geniculate nucleus of the thalamus. From there, it goes to the cortex, notably Heschel's gyrus or Brodmann's area 41 and 42 in the temporal lobe. I have some side notes on this slide as well. If we have a lesion somewhere in the nerve here, we will have a unilateral sensory neural hearing loss on that side. If we have some kind of lesion ipsilateral, because it is a bilateral pathway, we will not be affected by a unilateral lesion. So there's conduction, sensory, and neural portion to hearing. Where does it transition? This slide is another question where you can get a question off this slide. So conductive hearing loss is a lesion located between the environment, or where the sound's produced, and the organ of Corti. Bone conduction is better than air conduction, and it can be from wax in the ear canal, or a perforated eardrum, or fluid in the middle ear. This is kind of our conductive hearing loss. So a way to tell if you have a conductive hearing loss versus this other one, the sensory neural loss, is if you take your index finger and stick it in your left ear and then start to hum, it will be louder on the ear that is covered versus the ear that is not. This is similar to having wax in the ear or a perforated eardrum. The sensory neural hearing loss is a lesion central to the oval window. It may therefore involve the cochlea or the sensory portion, the cochlear nerve or nuclei, the neural portion, or the central auditory pathways. Difficulty hearing high-pitched sounds and vowels in both air and bone conduction are diminished in a similar extent, although air conduction remains a little bit better than bone. So here is the neuro test, or part of the neurological exam for somebody coming in, and we look at first the Weber's test. This differentiates a conductive hearing loss from a sensory neural hearing loss in a unilateral hearing loss presentation. So you'll click your tuning fork and you place it on the midline skull. Normally the vibrations are perceived equally. There's no lateralization because bone conduction is equal bilaterally. If you have a conductive hearing loss, the vibrations are louder in the deaf ear. So the patient says, Doc, I'm having trouble hearing on my left. You click that little vibrate tuning fork, you stick it on their head, and you say, what do you hear? They say, I hear it on both sides. You say, do you hear it louder on one? They say, yes, on the left. Versus the next patient that comes in who has a sensory neural hearing loss where the sound is louder in the normal ear. And they say, Doc, I have trouble hearing on the left. So you click your tuning fork, you put it on their head, you say, does one side sound louder than the other? And they say, yes, it does on the right, because they have a sensory neural hearing loss. So that is one way they differentiate between the two. The second test is called Rene's test. It compares the patient's air versus bone conduction. The stem of the vibrating tuning fork is put on the mastoid. When the patient no longer hears the vibration, the fork is then placed next to the ear. So while it's on the mastoid, that is testing your bony conduction. While it's off your body but just next to your ear, that's the air conduction it's testing. In normal individuals, because air conduction is better than bone conduction, the vibrations are perceived in the ear after they are no longer perceived at the mastoid. It's normal or positive when the tuning fork is heard approximately twice as long by air conduction as by bony conduction. So a normal patient walks in, they say, we're just going to test your hearing. They say, okay, you click the tuning fork, you stick it on the mastoid, and say it goes for about 10 seconds. And the patient says, I don't hear it anymore. The doc puts it by their same ear and says, do you hear it now? They say, yes, I do. And the doc continues to count and gets past 20, and they say, do you still hear it? They say, yes. You say, okay, your hearing is normal. Versus somebody that comes in and says, Doc, I'm having trouble hearing something on my left. Here we need to decipher a conduction versus sensory neural loss. So a conduction loss has bone conduction better than air conduction, and therefore the tuning fork cannot be heard when it's placed next to the ear. So the person that has hearing deficits in the left, the doc clicks the tuning fork, puts it on the mastoid. Can you hear this? He says yes. He starts counting. He gets to 10. Patient says, I can't hear it anymore. The doctor removes it, puts it in front of the ear. Can you hear it now? He says no. So bony conduction is better than air. In a sensory neural loss, both air and bone are bad, but air is better than the bone. So patient says, I have trouble hearing my left. The doctor clicks the vibratory, puts it on their mastoid. Can you hear it? Patient says, yes. Tell me when you can't. Doctor counts to only about 3 now. He says, I can't hear it anymore. He says, okay. Moves it in front of the patient's ear. Can you hear this? He says, yes. Starts counting. He says, I can't hear it anymore. Doctor only got till 6. So air was still better, but it's still worse than normal. So if he put it on the right side and did all that again, maybe he's at that 10 or 20. And these are all made up numbers, so don't remember the numbers. But that is how you test a conductive versus sensory neural hearing loss, and especially using these neurological exams. So now let's jump into the ABRs itself. We have to know how to set it up. So if you want to pause the video and take a stab at it, do these according to the ACNS or ANS guidelines and see how you do. Okay, we'll get going now. Stimulator is we are going to use earbuds, and the type of sound is clicks. The duration is 100 microseconds broadband click. It's alternating in the operating room. We'll go over all this in more detail. This is kind of just the memorization stage. Delivery, you give it a mono-orally or just to one ear, and you have it interleaved just like we did with the SSEPs, so we can collect data quicker. The rep rate is less than 20 hertz for optimal amplitude. 10 to 19 hertz is most likely the best range, and it cannot be divided by 60. I know in my program I use 11.1 as my starting point. Intensity is 100 decibels per sound pressure level, or 60 to 70 decibels hearing level. That happens to be the same actual loudness, but just in a different scale. Masking is this kind of white noise, and it's recommended to do 60 decibels per SPL, or 30 to 35 decibels hearing level, and usually use that in the contralateral ear. Filters, the low cut is at 30 hertz or 100 to 200 hertz in the presence of active EMG, and the high cut at 15 to 2000 hertz. 6 decibels per octave filler roll-off for the low cut, and 24 decibels per octave for the high cut filters. The analysis time is 10 to 15 milliseconds. Sensitivity is 1 microvolt, so we know we got pretty small amplitudes here. The number of averages is 1,000 to 4,000. That's a lot of averages. The second tip off that we probably have small amplitudes. The head leads is the non-inverting positive at CZ, and the inverting or negative at A1, A2. That non-inverting inverting just has to do with our differential amplifier, which we'll get into a little bit later in a different section. And we don't use notch filters. So stimulator, broadband clicks are used in the OR at a duration of 100 microseconds in order to provide a broad spectrum stimulus activating much of the basilar membrane. So why do you use clicks? Because you want to activate a large part of that basilar membrane. Small earphones are used in the operating room in order to stay out of the surgical field. If small electromagnetic earphones are used to generate the stimuli, then alternating polarity clicks are preferred to reduce the high amplitude stimulus artifact. A tube is also used to connect the earbuds to the stimulator, causing a 0.9 to 1 millisecond delay in latency. So if you were going to look at normative data of an audiologist using BAERs in their clinic that is using headphones, their onset latencies will be shorter than yours, because we are going to be using these tubes, which adds a 1 millisecond delay to when we start to see our response. When we stimulate, we have 3 choices here. We can stimulate with condensation, rarefaction, or alternating clicks, and this has to do with the pressure and the way the tympanic membrane is bounced, pretty much. So first, condensation. The movement first causes compression or condensation in the air near the tines. This may be defined as an area of increased density compared to the overall air mass. The increased density increases pressure or has a positive pressure, and the human ear is sensitive to this increase. One reason why you may elect to use compression or condensation is it may increase the wave 5 amplitude. So if we look at the upper left, or in the blue box there, we have the headphone, the tympanic membrane. Condensation pushes that membrane inward. Rarefaction is the next one. When the tines move in the opposite direction because of their elasticity, the air's elasticity causes it to return to its former volume. Because of the inertia of the air mass, the mass overshoots and extends beyond its original volume. Now the density of this portion of air is less than the atmospheric pressure or a negative pressure. Thus, an area of rarefaction succeeds the area of condensation. The ear is also sensitive to this decrease in pressure. It may cause, and you would choose to use this to increase your wave 1 amplitude, but it will also change its latency. It will decrease a little bit. And to separate wave 4 or 5, which we'll see in a couple of diagrams I have later, where wave 4 and 5 can kind of blend into each other. So condensation, compression, pushing it that tympanic membrane. Rarefaction, it's pulling that membrane. Or I think of it like retraction, rarefaction, pulling it. That's just how I remember it. So condensation, rarefaction, and alternating clicks. The positive pressure moves the diaphragm towards the tympanic membrane and is called condensation click. The negative pressure moves the diaphragm away from the tympanic membrane and is called rarefaction. The alternating of condensation and rarefaction click is called the alternating clicks. Rarefaction is the most common polarity used for BAERs, but most use alternating current in the operating room to reduce stimulus artifact or cochlear microphonic responses. So, according to our guidelines, best practices is to start with alternating clicks, and then if you talk to audiologists, they might start off with rarefaction because that's what they're used to doing. And if you're not getting a response the way you want, then you can change to rarefaction and then sometimes even check out condensation. But that's usually the lowest in the pecking order. So here we look at alternating clicks. For cochlear microphonics, they are the phasic reaction of the cochlear hair cells, and the potential appears as a series of waves merging over wave 1 of the BAERs, especially with high intensity. So we get this stimulus artifact coming from these cochlear hair cells that can overlap wave 1, making it unreliable. When we use alternating clicks, like on the last trace at the bottom, it gets rid of this cochlear microphonics, and we have a nice smooth wave until we get to wave 1. The clicks are delivered monoaurally and interleaving and is used to stimulate only one ear at a time. If not using interleaving but rather sequential, the non-stimulated ear may need to be masked with a white noise at 60 decibels per SPL or 30 to 35 decibels hearing level to eliminate crossover response or bone conduction response originating from the non-stimulated ear. So if you have them going at the same time, you can potentially cause a false negative because of bony conduction causing a response in your waveforms. So in that case, you want to have a 60 decibel white noise in the contralateral ear to make sure that that does not happen. Our rep rate, recommended between 10 and 19 hertz, less than 20 hertz for optimal amplitudes. Wave 3 is the most susceptible to fast rep rates. So when we're in the operating room, we're looking at wave 1, 2, 3, 4, and 5. Wave 2 and 4 are almost always not so great, so to the point where we honestly don't even look at them in the operating room. The next one, as far as being poor replicating, is wave 3. It's a far field wave and it's smaller in amplitude. The next one in line is wave 1. The saving grace for wave 1 is that it's a near field potential. Wave 5 is our strongest waveform. It's the most reliable one. It's the one that we are going to be monitoring and looking at the most, and it's the easiest to replicate because it is the largest amplitude. And as a matter of fact, when you're in the operating room and you're doing BAERs, you identify wave 5 first and then count backwards from there. Back to rep rate. Other authors have argued that the rates of up to 40 to 50 hertz should be used for any speed of acquisition. If any decrease in amplitude, then you can go back down to 20 hertz. So because these are very small amplitudes, we have such a large amount of sweeps that we need to obtain a reliable response. So some authors will push the rep rate to a higher amount in order to collect data in a reasonable time. And of course, we can't have it divisible by 60 or 50 in the UK. Intensity. This one gets a little bit confusing just because they're very similar terms, even though that they're measuring from a different starting point. Intensity in the air being stimulated should be at 100 decibels per sound pressure level or 60 to 70 decibels hearing level. Damage to hearing is seen at levels greater than 110 decibels per SPL. I don't know if you remember that picture, but that was getting in the territory of a plane taking off, how loud it is. Decibel Sensation level is the sensation level to sound for a particular individual. This allows you to find the sensation level of both ears and use those measures to match a stimulus intensity. Decibel hearing level is the measure comparing sound intensity to the hearing thresholds of the normal young healthy adult. So it's their sample of young healthy adults. The decibel hearing level of 0 is normal. This is the decibel scale used by audiometers. Normal hearing level is the average threshold of the normal adult. This is the one we use. A decibel sound pressure level is the root mean square pressure of a sound relative to the lowest intensity sound that can be heard by the most sensitive ear. So now we're not talking about normal, we're talking about very sensitive ear. This is usually given by the manufacturer and is somewhat around 0.0002 dimes per centimeter squared for a tone of 1000 hertz. This is the decibel scale used by sound meters. Decibels per sound pressure level is the reference to a physical measure taken from the intensity of a long duration sound that has the same amplitude as the peak sound pressure level of a short duration sound. So if you're stimulating at 100 decibels per sound pressure level and normal hearing for that group is 25 decibels per sound pressure level, what is the stimulus intensity? This is just knowing the simple subtraction is 75 decibels SPL, but that's if we're going off of normal hearing levels of a group or the DBHL. What if we wanted to figure out for sensation levels? Here's the math. If there is a decibel sound sensation level of 20 decibels per SPL in the left and 30 decibels per SPL in the right of that one individual, I'm probably going to stimulate the right ear at 10 decibels per SPL more to get the equal stimulation intensity of 80 decibels per SPL. So on the left side you have 100 minus 20 equals 80 decibel SPL delivered to the left versus 100 minus 30 is 70. Filter settings. We have a low cut of 30 hertz or 100 to 200 hertz if there's too much EMG artifact or muscle artifact. A high cut of 15 to 2000 hertz. 6 decibels per octave filter roll-off for the low cut, and the more efficient 24 decibels per octave for the high cut filters, and no notch filter. The analysis time. Analysis time is used is 10 to 15 milliseconds, where 15 milliseconds is typically used in the OR in case there's any pre-surgical deficits causing an increase in latency. So 15 is definitely recommended if you're doing something like an acoustic neuroma. However, I find 10 to be more useful if I'm doing something like an oral Chiari malformation, where the Chiari, we're pretty sure that they're going to have intact hearing, so we're not worried about that prolonged wave 5. Having a shorter analysis time will make smaller latency shifts more apparent because it will be blown up on the screen a little bit easier. So I choose to move it to 10 when I do those cases. Outside the operating room, kids under 2 years old may also require this prolonged 15 millisecond analysis time, where adults are looking at 10. In the operating room, only the short latency ABRs are used. These are relatively unaffected by anesthesia and level of sedation. Middle and long latency BAERs are wiped out by anesthesia. So if we look at the picture here, we have 3 groups, the SLR, MLR, LLR, and that's just the short, middle, and long latency ranges. And on the left side of that blue line, we see the waves 1 through 5. Those are the only ones we're interested in the operating room. There has been some studies looking at these MLRs, the middle range ones, to see if we can adequately assess depth of anesthesia or likelihood of the patient having some sort of awareness or waking up. There has been some credibility to what's been published, but nothing that is substantial enough, or we'd probably be using it ourselves. Sensitivity. Since there are such small waves, the sensitivity can be set to 1 microvolt. Number of sweeps is 1,000 to 4,000. The amplitude of the BAER, less than a microvolt, are smaller than other potentials like SSEPs, which is a couple of microvolts. These are more susceptible to larger amplitudes of background noise. So a large wave 5 is about 0.5 microvolts. Wave 1 is probably closer to 0.3, somewhere around there, and wave 3 is probably 0.25 to 0.3, somewhere in that range. Again, we went over signal to noise ratio a lot with SSEPs, but the most short latency ABRs are sub-microvolt ranges, are invisible to usual analog recordings or signals. This is because the potential is smaller than the non-event related activity or the noise. This is said to be a poor signal to noise ratio. ABRs are far field potentials, except for wave 1, because they are generated in the brainstem, transmitted through the electrical conductive fluids and tissue in the brain, and recorded in the scalp. ABR signals can be 100 times smaller than the artifact encountered in the OR, like EMGs or eye movements or other musculature, 60 Hz noise, slow skin potentials, respiratory artifacts, etc. The stimulus-dependent portion of the signal, or the evoked potential or nerve action potential, are similar in amplitude and latency in each epoch, averaged and appear in the average result, whereas the stimulus-independent or random portions of the signal, like the noise, differ substantially from epoch to epoch and are suppressed by averaging. So I did have a bunch of additional mathematical equations that showed, because of the small amplitudes versus something like a sensory nerve action potential, how many sweeps or traces are needed, between a difference between the two. But you can go back to the prior videos and work that math when I went over the signal to noise ratio there. Head leads. We have a non-inverting positive at this CZ, an inverting negative at A1 or A2 for all waves. Wave 1 is a negative wave. It's the only wave. All the others are positive. So since it's the only one, you should remember that. Wave 1 is the only negative wave. That is generated by a near-field response of the distal auditory nerve. Again, it's the only near-field response. It's a negative near-field response. The A1 lead is the active lead. It's the only wave. The others are all CZ active, but is placed in the channel 2. This makes the wave positive, just like all the other channels, but for a different reason. Placement of the A1, A2 electrode over the mastoid, or M1, M2, can produce post-auricular muscle artifact, and this is a stimulus muscle artifact that usually happens later in the response past wave 5. All right, so where are each of these waves generated? This is a picture that you just have to commit to memory. So we're going to start from our earbud inside the canal, causes a click, causes that mechanical and neural sensory summation of a potential, and we now find ourselves in the very distal cochlear nerve as that action potential is summating up. That is where wave 1 takes place, at the very distal portion of the cochlear nerve. Wave 2 is at the proximal portion of that nerve, possibly also entering into the brainstem. Wave 3 is in the dorsal cochlear nucleus. Wave 4 is somewhere in that pontine area, the superior olivary complex, possibly the lateral lemniscus. It probably has multiple generators, just like most of these do. And then wave 5 is at the inferior colliculus, also the more rostral area of the lateral lemniscus. Okay, so now we are on to the blood supply to the generators or areas of the hearing pathways. The inner ear is supplied by the internal auditory artery, which is usually a branch off the anterior inferior cerebellar artery. So those are two main vessels that you need to know for the ABRs. The internal auditory artery, which has an AKA of labyrinthine artery, and the AICA, or the anterior inferior cerebellar artery, that is usually coming off the basilar artery, but it also has some anatomical variations coming off of the vertebral arteries. Within the internal auditory canal, the internal auditory artery irrigates the ganglion cells, the nerves, the dura, the arachnoid membrane, and divides into two main branches, the common cochlear and the anterior vestibular arteries. I do not think that they're going to go that deep into the anatomy. The common cochlear artery further branches into the main cochlear artery and the vestibular cochlear artery, the latter forming the posterior vestibular artery and the cochlear ramus. Again, I don't think you need to memorize all those, but luckily the name matches where it is in the cochlea or the vestibular canals. The main cochlear artery supplies the apical 3/4 of the cochlea. The cochlear ramus irrigates the basal 1/4. So here we have our two major vessels that we need to know, the AICA coming off that basilar artery mostly, and the labyrinthine artery, which is the AKA for that internal auditory artery. And then we see it splitting off into these other branches that were labeled before. Here's our circle of Willis, and we see right smack in the middle is our basilar artery. Coming off of that is our anterior inferior cerebellar artery. The branching off of that is the labyrinthine artery. What I put this up here to show is sometimes there can be some anatomical variance where it's coming off the basilar artery. Other times it's coming off of the anterior inferior cerebellary artery. Here we have slides or slices of spinal cord and brainstem showing different vasculature supplies to different areas. So the cochlear nucleus gets blood supply from the branches of the pica and AICA, which we see over in this area here. The superior olivary complex and the lateral lemniscus are supplied by the circumferential branches of the basilar artery. So now that we are looking at the blood supply and the nuclei that it supplies to, we should try to relate that to the wave that is generated in that area. Cochlear nucleus, we're talking about 3. Superior olivary complex, we're talking about possibly some 3, a lot of 4, probably not 5 yet. The inferior colliculus, now we're talking wave 5, is vascularized by branches of the superior cerebellar and quadrigeminal arteries. Probably superior cerebellar would be the answer if that was on the test. Okay, setting up the program. The montage will be CZ to the AI, where the I is ipsilateral, CZ to auricular contralateral, and then there's a third one that is not an obligate peak. You won't see it in the ASNM guidelines, but if you are doing BAERs, I highly recommend you put it in there, and that is the AC to the AI. Because these are all positive waveforms except for the wave 1, typically you will see this phrase vertex positive, where CZ is the active electrode because it's vertex positive. So all the scalp positions show electropositivities, particularly at the vertex. So that is why we use that as our active area to get these positive waveforms. In the auricular ipsilateral to CZ and the auricular contralateral to CZ, waves 2 through 5 are recorded as upward negative peaks because the auricular ipsilateral and auricular contralateral become more electronegative than CZ at the corresponding latencies. So all they did there was switch your active and reference electrodes, and it becomes more negative than before. Waves 2 through 5 have larger amplitudes at the vertex. This is not the same with wave 1, which is more like a near field potential, where waves 2 and 5 are recorded at distances from the brainstem generators and are thus far field potentials. The AC, or contralateral to the auricular ipsilateral, may be used to better enhance wave 1. So if we're looking at our picture here now, we try to find wave 5, which is our largest amplitude here, and we can see that it's not always at the same latency. It's sometimes overlapped by wave 4, like we see in the top tracing, and it's always not the most, it's not present on all traces. So this, we have our best trace here on the ipsilateral one, which has some wave overlap, wave 4 overlap. We also have a very good wave 1 on that ipsilateral and also on this third trace that we bring in. But we see CZ to AC does not have a very good 3, but it has a pretty good 2, and it has a good 4. This 5 is separated off of 4, which is also helpful. If we wanted to try to get this wave 4 off of the wave 5, we might switch from using alternating clicks to rarefaction, which is known to parse those out, and we might end up with 2 isolated wave 5s, and we might choose to go with that. So that's something that you establish when you're getting your baselines. Volume conduction. The electric current passes through the auditory pathway, but the responses generated are not due to anatomical structures. It is the signal spread through conductive sources like blood, CSF, or brain tissue that is being recorded over a wide area over the scalp. This is called volume conduction. This is how far field potentials are generated from wave 2 to 5. This does not happen in wave 1, which is a negatively charged near field potential to the ipsilateral stimulation site. Volume conduction, the body can conduct electrical signals through salt water, a process called volume conduction. Flow of current through any part of the body follows 3 rules. First, if the tissue resistance is equal, electric current will flow evenly in all directions. This is why near field can be conducted over only short distances and far field over very large distances. Number 2, current flows in the path of least resistance. We already know that from our pedicle screw stimulation. Number 3, the amplitude of the potential at the recording electrode varies inversely with the square of the distance between the generator and the recording electrode. So you do need to know that, the square of the distance between those two. In general terms, or in clinical terms, it just means the further you are away from the generator source, the smaller or worse your potential is going to be. Here again, we have a couple of BAERs. We look at the top trace, we have all 3 of them present, and the bottom we have no wave 1. It has nothing to do with the patient's presentation, but it does have everything to do with the setup and what's our near field response. So a right brainstem auditory vocal response is recorded. Notice the clear wave 1 on the A2 to CZ, which is ipsilateral to the stimulation, versus the wave 1 of the A1 to CZ, contralateral to the side of stimulation. So is there anything we should know about each individual wave? We're going to break it down each wave to know when where the generator is, what the vascular supply is, and if we're having trouble recording it, what are some technical moves we can use. Before we do that, let's look at the upper right corner. Here we have listed each wave 1, 2, 3, 4, and 5. We have what's called interpeak latencies. We typically use 1 to 3, 3 to 5, and 1 to 5. If we start to see a shift in latency, which we'll get into more with our alarm criteria, but that is the most sensitive criteria for deficits that's happening in the auditory system. So instead of looking at absolute latencies, which means this wave, this line here is the absolute latency from onset to wave 5. If it moved out, that absolute latency would start here and be, say, here. But if we look at interpeak latencies from wave 1 to wave 5, but now there's deficit 1 to 5, that seems to be a better predictor of post-op deficit, and it enables us to identify where the lesion is. So if we have an increase in 1 to 5, and we have an increase between 3 and 5, but we have no increase between 1 and 3, we know that the lesion has to be somewhere distal, or actually more rostral to the cochlear nucleus, where wave 3 is generated. Here is normative data that is used from probably the diagnostic world, because the latencies are a little bit shorter, and it's just showing the differences in latencies when you have a higher intensity stimulation versus a lower. You see an increase in latency, and we'll look at that a little bit more later on as to what happens to those waves. So isolated waves. Wave 1. is considered a near-field potential recorded primarily from CZ to AI. It does have far-field contributions as well, but if asked on a test, choose near-field. If it is present in the CZ to AC, suspect crosstalk from the other ear via bone conduction. If that's happening, then you should probably turn on your white noise to mask that other side at 60 decibels SPL. This is the only wave that is not a positive polarity at CZ. It's actually negative. Wave 1 is a negative potential rising from the stimulated ear. This negativity at input 2 using the CZ to AI position results in the same upward deflection as the later positive peaks that are positive polarity at input 1. It represents the volley of the distal auditory nerve or the cochlear nerve action potential, so distal. Latency matches the peak of the action potential in electrocochleography, that's N1. Wave 1 amplitude is around 0.2 microvolts and a 1.7 milliseconds in latency. Wave 1 and 3 are most affected by decrease in amplitude with an increase in rep rate, more so than wave 5. You'll see for most things, wave 5 is a tougher wave than the other one. So if you increase the rep rate, or if you start going to hypothermia, or if you decrease the stimulus intensity, wave 5 is the one that seems to always hang in there. Wave 3 is the first that goes away, then wave 1, and then wave 5 eventually will. Rarefaction may increase its amplitude, but also decrease its latency. Wave 1 to 3 is the most specific for acoustic neuromas. It's the least affected wave by lower temperatures. Blood supply, so I think I might have said that wrong before. This one is actually the least affected by lower temperatures, most likely because it's near field. Blood supply is the labyrinthine artery. The N1 of the electrocochleography is equivalent to wave 1 of the ABR, and this is a stationary potential. Wave 2 is an inconsistent wave not used in the OR. You may have a better waveform from CZ to AC over CZ to AI, generated from the auditory nerve, but more proximal portion than wave 1 and possibly the cochlear nucleus. Latency is around 2.8 milliseconds. Blood supply is again the labyrinthine artery. Occurs at the same latency as N1 of the ANCAP when the electrode is placed at the auditory nerve root entry zone adjacent to the brainstem. There is no relationship between the near field recorded N1 of the ANCAP and the far field wave 2 of the ABR, the scalp recorded at wave 2, and the negative peak between. Changes in this waveform signal dysfunction of the proximal part of the eighth nerve, as it is in the case of retraction of the eighth nerve during a CPA tumor surgery. This is also a stationary potential, also a far field like all the rest besides 1, a positive wave like all the rest except 1, and CZ is the active electrode like all the rest except for wave 1. Wave 3 appears midway between wave 1 and 5. Amplitude is larger than wave 1, smaller than wave 5. Latency is about 3.9 milliseconds. It may have, so if you haven't caught on yet, when you go, the difference in latency from one wave to the next is equal to 1 millisecond. So if you're checking the inter-peak latency of 1 to 3, that would be a 2 millisecond difference. It may have a larger amplitude and shorter latency with the CZ to AC than the CZ to AI. The generator is around the cochlear nucleus, the superior olivary complex, and lower half of the pons. Changes in wave 3 may also occur from the process affecting the lower part of the pons. As with other potentials, the transmission above this level is affected with changes or loss of wave 4 and 5, with the increase in absolute latency of wave 5, and the increase in the 1 to 5 interpeak latency, and perhaps the 3 to 5 interpeak latency if wave 3 is still recordable. It's a positive charge and CZ is active. Wave 4 is better separated from wave 4 and 5 in the CZ to AC than the CZ to AI. Not used a lot in the OR. Seems to come from many areas like the cochlear nucleus, the superior olivary complex, and the lateral lemniscus, and possibly even the trapezoid body. Appears to be generated by events contralateral to the stimulated ear. It receives contributions from both sides of the brainstem, however. Latency is about 5.1 milliseconds. Of course, it's a positive. Of course, CZ is active. Of course, it's far field. Wave 5 amplitude is the largest at 0.5 microvolts. The sharp peak of wave 5 is generated by the lateral lemniscus as it terminates into the inferior colliculus, and that activity of the inferior colliculus is responsible for the generation of a relatively slow and large negativity peak following the wave 5. Latency is about 5.7 milliseconds. Decreasing in the stimulation prolongs the latency of wave 5, but it should outlast all the other waveforms in amplitude. Decreasing the intensity can be used as a tool to better identify between wave 4 and 5. When it does overlap, say you have an overlapping, you're trying to figure out where to put your markers at, but you can't tell where 4 and 5 is. You go from 100 decibels per SPL, you crank it, or you turn it down to 60, and then you see that 4 and 5 separate. And then you can stimulate at 70 and 80, then 90 and 100, and you can kind of track it back up and keep your marker on that wave 5 amplitude. It's generated in lower midbrain or the inferior colliculus and the lateral lemniscus in the higher pons. It's best seen in the channels of AI to CZ and AC to CZ, and sometimes absent in the AI to AC. It's less affected by increased rep rate over 20 Hz than wave 1 and 3. Wave 5 latency increases by 0.2 milliseconds per degree centigrade drop in temperature. Condensation may increase its amplitude. CZ is active, positive wave, far field potential. Keep going with wave 5. Is particularly useful in CPA surgeries when retraction of the cerebellum and stretching of the proximal part of the 8th nerve causes an increase in its absolute and wave 1 to wave 5 interpeak latency, as well as changes in its morphology and a decrease in its amplitude. An increase in wave 5 latency is usually the most common and earliest sign of dysfunction. Changes in wave 5 can occur if damage or dysfunction arises anywhere distal to or at the level of the mid and upper pons or lower midbrain inferior colliculus. Inappropriate stimulation causes changes here. First, the waveform most commonly followed and measured, especially its latency. The loss of this wave is associated with significant post-op deficits. So wave 5 is our go-to wave when we're deciding if the patient is going to have some kind of problem or not. Waves that follow wave 5, wave 6 and 7, they're not monitored in the OR. They're generated in the medial geniculate body of the thalamus and auditory radiations up into the cortex of the temporal lobe. So what are we going to measure? We measure the wave 1 and 5 most commonly. We also measure wave 3 though, and the 1 to 5 interpeak latency, as well as 1 to 3 and 3 to 5. We measure absolute latencies, or how long it is from onset to that wave. We measure the amplitude size, and we measure all interpeak latencies. Alarm criteria. Like all invoked potentials, the alarm criteria should reflect the degree of variability in the data. Sudden changes should be considered more significant. A 1 millisecond or 0.5 milliseconds stated by some other authors, or a 10% increase in peak latency of a component is considered significant. I think most authors consider 0.5 milliseconds as an early warning sign, although there has been some studies that show some deficits that happen less than 1 millisecond, but most consider 1 millisecond to be the alarm criteria to alert your surgeon. Another criteria is a 1 millisecond or 0.5 milliseconds stated by some authors, or a 10% increase in the interpeak interval of wave 1 to 3, 3 to 5, and 1 to 5. And the last one is a reduction of 50% of the amplitude. So where was this nerve most likely cut? If we look, this is a very grainy, poorly filtered type ABR. If we look over to the right, we can kind of orient ourselves as the time. This is probably coming somewhere around 2, maybe a little less than that. That makes me suspect that this is wave 1. Wave 1 is a very distal portion of the cochlear nerve. I see no wave 2 replicating at all, which would be the more proximal cochlear nerve. We don't get wave 2 a lot, so I can't rule it in or out just because it's a poorly replicating generator source. So we are probably cut somewhere along the cochlear nerve, but not the distal portion of it. That is still intact, that is still generating a response. Central lesions in ABRs, wave 1, 2, and 3 are present, but wave 2 and 3 are a little bit delayed, with all other waves absent. Does this make sense with the tumor that destroyed their midbrain and pons? So if wave 1, 2, and 3 are present, 2 and 3 are a little bit delayed, that would cause some kind of compression on the cochlear nucleus and possibly the nerve itself as it exits, or possibly some stretch on the nerve, making it delayed so it's still present but not completely normal. And then wave 5 is aberrant, so that would make sense clinically. A basilar artery infarct, what do you think was the last anatomical structure unaffected by ischemia? So here's where we have our first trace, and then we have a basilar artery infarct, and we still have a very good 1, 2, 3, and 4, but wave 5 is now gone, and even these later generators that we typically don't look at are also gone. So here we're looking at a pontine or rostral type lesion from a basilar artery infarct. Here we see, this is probably the most common change you're going to see, is we're doing one of these suboccipital cranies or retromastoid or something, and the surgeon has now inserted his retractor and is pulling the cerebellum out of the way to better visualize where he's going to be doing the surgery. And we see this shift out of wave 5 and wave 3 here. Wave 3 is starting to diminish, wave 5 is hanging on, but it's definitely shifting out in latency. At that point you say, "Doc, I have a change." He says, "Well, what is it?" You say, "It's most likely due to the retractors. Can you take them out and let it rest?" Retractors come off and we see it shift back towards there. At that point you say, "All right, Doc, I have still a slight decrease in latency, but the amplitude has come back completely." He may then elect, or she may then elect, to continue on with the procedure, but do much less retraction in order to see that, or hopefully he's already ordered some of these diuretics to make sure the brain swelling is down a little bit, because it's probably going to be too late at that point, to tell you the truth. All right, again, we have a very grainy picture. If we look up in the upper left, we have a very nice wave 1. We have nothing there for wave 2, 3, or 4, and we have this very poor wave 5. It's very hard to even call that something replicating. Then all of a sudden we have nothing there. So if it is technical, it could very well be that the tube could have fallen out and our stimulator is bad. Fluid could have gone in the ear, something of that sort. That's common causes that could happen in the operating room. You know, he's not going to build up your wax in an hour. That'd be more towards baselines. If it's a pathological area, then we've lost wave 1 as well as wave 5, so we have to think it's very distal out there. Most likely that would be a vascular problem, something on one of those more distal branches off the labyrinthine artery. This patient, if it is truly a pathological lesion, is probably going to wake up with some hearing deficit. Acoustic neuroma BAER testing. The acoustic neuroma, there is a stretching of the cochlear nerve causing an interpeak delay between wave 1 and 5 as the most common presentation. So here on the top we have a normal ABR, wave 1, 2, 3, 4, 5, very similar interpeak latencies. Here we have 1 and 2, 2 is still where it should be, 3 has now moved all the way out, and 5 has now moved all the way out. Just to be honest, this is not an acoustic neuroma patient. This is actually a multiple sclerosis patient, which is why they have a good peripheral area, but the central plaquing is causing slowing and conduction. But if you were having some kind of vascular change or some kind of tumor change, it might present very similar to what this picture is depicting. Although we might also, if it's a CPA tumor, we might also see 2 being affected as well. Surgery types, retromastoid approach. This is done to preserve hearing and still completely remove the acoustic neuroma. In some cases, because of invasion of the auditory nerve by the tumor, it is necessary to sacrifice hearing in order to completely remove the tumor. The success of hearing preservation in these cases is largely dependent on the size of the tumor and the condition of the auditory nerve in relation to the tumor. So that's one approach. If you see on your intake that you have a retromastoid craniotomy, chances are that they are going to want BAERs, and they're going to want to test BAERs and hope to maintain whatever hearing they might have. A translabyrinthine approach is the most versatile but may cause permanent hearing loss due to violation of the membranous labyrinth. The surgeon may opt for this approach if there is a poor audiogram or BAERs preoperatively. So now if you see a translabyrinthine approach on your chart, you might even say to the surgeon, do you even want ABRs? Because chances are you're going to lose any hearing that this patient already doesn't have, so it's kind of a wasted effort. Medial fossa approach. This approach is typically reserved for patients who have a small tumor and who have good hearing in the affected ear, since it may be permanent preservation of hearing and still remove the tumor. This technique has significant limitations, and then they may not be able to remove the whole tumor and in half of all patients, and may cause trouble to the facial nerve. This approach I've done, but I really don't see it very often. It's the first 2 that are the 2 that we see. Effects on intraoperative BAERs. Hypothermia increases latencies and decreases amplitude, whereas hyperthermia decreases amplitude and latencies. They are inversely related to temperature changes at a rate of about 0.2 milliseconds per degree centigrade. Hypotension will cause a bilateral decrease in wave 5 amplitudes, which makes sense as a central wave there. Conductive loss will increase absolute latency but not affect interpeak latency. Increase in ambient noise or drilling can cause attenuation or dispersion of waves, especially wave 1. These changes are benign or may mask injury because of the nerve. So when you're doing these BAERs, they usually got to crack open the cranium, and they use a drill quite a bit. So during the time of drilling, ABR is pretty much unreliable. And even shortly after it causes this transient type deafness or loss of hearing, which usually resolves right after it. Opening the dura has shown increase in latencies, most likely due to temperature changes and changes in the environment around the acoustic nerve. These changes are benign. This is the one that's most problematic, I'd say, because you're got your baselines, you're all ready to go. He opens up the dura, and then you have a latency shift happening at a very similar point in time when he's going to be putting the retractors in there to move the cerebellum. Just something you have to work around and make sure everyone's on the same page, and make sure that you have baselines that are representative at that point in the case. Artifacts. Electrical stimulation artifact seen at the beginning of the wave, like we see in A. B is a bipolar cautery. C is the CUSA, or cavitational ultrasonic surgical aspirator. High frequency artifact that won't be rejected and causes flattening of the waves. D is an external electrical equipment causing 60 Hertz. E is a post-auricular muscle artifact. So I talked about this a little bit before, but this is when you have your recording electrodes over the mastoid as opposed to in front of the ear. You get this large muscle artifact that happens after the waves that we're recording, but still can distort them as well. The drill causes acoustic masking through bone conduction, and the EKG is seen more common in referential montages. A question that they like to ask is the deafening caused by drill, and it's right there through bony conduction. So you should not choose anything that makes it look like a sensory neural loss. It has nothing to do with the nervous system. It has to do with conducting sound through bone. So just remember that and try to figure out the answer according to that, because they've asked it a couple different ways. Temperature changes on BAERs. So if we're looking at, let's see, at the very top we have 36 going to 37. So at the time of closing it's warming up, and we can see the slight change, especially in wave 3, to these temperature changes. Anesthetic considerations with intraoperative BAERs. Inhalational agents like nitrous results in a linear decrease in amplitude with no changes in latency. Inhalational agents like isohalothane, enflurane, placebo, and DES show mild increases in latencies. Intravenous agents, propofol increases the latency of 1, 2, and 5, but no changes in amplitude. Barbiturates and ketamine increases interpeak latencies. Since we are looking to use interpeak latencies as a sensitive alarm criteria, the fact that we have a couple of medications that increases those is kind of unique and something that we should be aware of, and it's something very testable. Fentanyl and narcotics really don't have any effect. Benzos, not really anything. Muscle relaxants, no effect at all. So the other ones you just need to know, absolute latency changes, very mild, but it happens. Not a whole lot of amplitude changes, but it's these barbiturates and ketamines that does the interpeak latency changes. So we're looking at these unlabeled traces and what else might cause this same presentation. So patients getting positioned, all of a sudden we have a very flat waveform, and we see a very small wave 5 that's way out there. And then we replace the earbuds and everything's good. So what happened is it probably lifted up a little bit out of the ear canal. It's still flapping that tympanic membrane a little bit, enough to get that wave 5, but it needed to be crammed back down in there in order to get a good reliable response. Something else that could be happen in this same portion of the procedure is when they start doing their prep. If you have not taped off that ear well enough, some of that betadine can drip into the ear canal and cause some kind of blocking of the sound, and you'll get that same presentation. So when you set the earbuds in there, make sure you not only tape those down, but you seal off the entire ear so no fluids can get in. As the decibel hearing level decreases, the morphology of the wave changes for the worse. There is an increase in absolute latency of the initial loss of wave 1 and 3. Wave 5 eventually disappears as well. So we're at the bottom, we have our nice recordable waveforms, and then as we keep decreasing the sound, we have a loss of wave 1 and 3 and eventually wave 5. So this is what I was speaking to before about when if we're trying to separate wave 4 and 5, we can use this. So right around, say, at 45, we see the wave 4 is gone. We crank it up to 55. Okay, we're still tracking back with wave 5, and then we could easily keep our marker there on wave 5. So how good are BAERs really? Hearing loss can be preserved better in microvascular decompression than acoustic neuromas. In microvascular decompression, traction on the nerve can be identified early and prevent injury. With large neuromas, they have had worse outcomes measured with hearing. The jury's still out on BAERs for acoustic neuromas for preventing an injury to cranial nerve 8. Our best efforts in there is preserving facial nerve in those acoustic neuromas. But if BAERs remain intact, there's a good correlation with an intact hearing postoperatively. Its weakness is predicting hearing loss, or it has a high false positive and false negative rates. Unfortunately, preservation of wave 1 and 5 does not even guarantee preserved postoperative hearing, as auditory function may disappear postoperatively, despite the presence of an immediate postoperative period, possibly reflecting postoperative cochlear artery spasm. So it's the artery spasms that we have to worry a lot about. That's probably, besides the retraction, it's the artery spasms that is the most likely cause of deficits. However, there is strong support suggesting that monitoring the facial nerve during acoustic neuromas is very effective in decreasing post-op deficit. Facial nerve monitoring has been more successful in acoustic neuroma cases than has BAERS in preventing injury, especially in large neuromas. Okay, so now ABR is time to troubleshoot. What would you do to a BAER to better monitor for ischemia of the labyrinthine artery? Our subject here says add direct nerve action potentials, or ECOG, which is good to put on a test, but realistically that's not happening in the OR that much anymore. You could try out rarefaction, try to get a larger wave 1. If stimulating at 90 decibels, you can crank it up to 100, or you could decrease the stim rate, especially if you're over 20 reps, rep rates. A patient has no sign of conductive hearing loss on audiogram or the Weber-Renes testing. They have no BAERS at baseline. What are you going to check? This looks like it's some sort of conductive block or malformation, so she's going to check for wax in the ear. Sometimes patients just have a large amount of ear wax, and you might have to actually clean that out a little bit in order to get a signal. There could be a kink in the tube. I see that written in a lot of study guides. It's hard for me to see how the tube could ever even kink in these cases, but maybe. Fluid in the ear hole, I've seen that. No or low clicks being produced, so you check your equipment. An earplug fell out, that's probably the most common problem that happens, or you're using an excessive rep rate, which you should know going into it. So what's worse, a stable wave 1 with no wave 2 and everything after that, so all you have is a wave 1, versus a stable wave 1, no wave 2, no wave 3, no wave 4, but wave 5 is present. A present wave 1 with everything else gone might be a retrocochlear lesion. That's not good. That's seen in patients with brainstem problems. Wave 2 and 4 and even wave 3 to a lesser extent aren't always going to be present. So if you have a stable 1 and 5, that's almost a normal patient according to BAERS alone in the operating room. Why is IPL probably a more sensitive measure of auditory problems than the absolute latency? That's the interpeak latency. Why is it better than absolute? A conductive loss of sensory loss can cause a reduced stimulus intensity, which prolongs the latency of wave 1. An interpeak latency is also minimally affected by the stimulus intensity or hearing deficit. Since the auditory pathway travels at about 20 meters per second, you can find deficits with slowing. This is easily picked up when there is an increase in the IPL. So you said you had a sensory neural hearing loss can prolong wave 1 due to poor high-frequency hearing. How can that affect the absolute latency of wave 5 and the wave 1 to 5 interpeak latency? You should have a scenario where wave 1 is prolonged due to a high-frequency loss, or you could have that. Wave 5 absolute latency might also be prolonged, but not to the extent of wave 1. This can make the interpeak latency seems shorter than normal. Usually it's about 2.4 to 2.5 meters per second interpeak latency, or about 4.7 to 4.8 milliseconds for wave 1 to 5 interpeak latency. This could even set you up to miss a more subtle IPL change in a wave 1 to 5 since it's abnormally short to start off. So what she's saying is in these high frequency sensory neural losses, wave 1 can be shifted out a little bit, but wave 5 is at its typical latency, which can kind of make interpretation difficult and can shrink those interpeak latencies. If the cochlear nerve is transected at the proximal end, just before it enters the brainstem, what might you see on BAERS on ECOGs and D synapse? On BAERs, you'll have a present wave 1, wave 2 possibly altered or missing, and everything else gone. On an electrocochliogram, N1 will be present and the cochlear microphonics and SP present too. On the direct CNAPs, wave 1 present, assuming that the electrode is distal to the lesion. So what he's telling you here is every wave 1 matches up with those other things, and it's earlier than the proximal recordings of the proximal cochlear nerve. Okay, this is the end of the ABR selection. I just wanted to remind you that I will be sending out some additional information on through email, so please check your email from either Joe Hartman or interoperative-neuromonitoring.com because these presentations aren't going to cover everything. It's obviously a lot, but I have some that I just took out because it was just too much for a free course. So I put some of it and some recap to what we're doing here and some of the notes that I'll be sending out over email. So make sure you keep an eye out for that. And I will see you on the next video recording.